A very good afternoon to everybody, a good morning to everybody. I'm Dr. NeetaSingh from Department of Maternal and Reproductive Health, SDPGI, Lucknow. And today I would like to talk on screening during pregnancy or screening of a pregnant woman. We all know that ideally any patient who is pregnant should have an antenatal care. And initially WHO had said that at least 4 antenatal visits are good enough for a woman, considering all our developing countries, underdeveloped countries and developed countries. But evidence has shown that 4 antenatal visits is not enough, and ideally it should be 8 antenatal visits. So what do we want to do during these visits? We need to take a detailed history of the patient, including her past obstetric history, if she had previous pregnancies, present history, what are her chief complaints, was there any family history which was significant and is likely to have an impact on this pregnancy, any history, medical history in their siblings, or any personal history. A good physical examination, at least on the first visit, will be very helpful. Then we need to decide some routine investigations which should be advised to all, and certain investigations which can be tailored to that particular patient, and accordingly treatment can be decided. The ultimate aim is that to have, at the end of the pregnancy, we should have a healthy mother and a healthy baby. The parameters which have been laid down to decide if these antenatal care is good enough are maternal mortality rate, perinatal mortality, stillbirth and neonatal mortality rate. And India tops amongst the stillbirth rate all over the world. So we have got a huge job in our hands. A paper published in 2020 from our country showed that in India, still on an average, only 21% of women have a full antenatal coverage. It varies according to the place, whether it is rural or urban, whether it is a higher or lower socioeconomic strata, or whether they are educated or not. So there are many things, but on an average, only 1/5 of the women receive full antenatal coverage. It is very important to understand that when a woman comes to us for her antenatal care, probably this is her first medical contact till now in her entire life. She never needed to meet a doctor, or she was never taken to a doctor. So this is a good opportunity to take a look at the woman, screen her and see whether she suffers from any disease which is specifically during pregnancy or apart from that. We also need to understand what are the physiological changes in pregnancy, and is it physiological or it is pathological. And certain diseases like preeclampsia, gestational diabetes in pregnancy, intrahepatic cholestasis of pregnancy can all lead to long-term diseases in the woman, and this is a wonderful time to pick up those women who are likely to have these diseases even beyond her pregnancy and to counsel her accordingly. The first and the most vital step in a good clinical practice is a correct diagnosis, and hence this will come from a good history, a good examination and tailored investigations, because treatment comes only after that. When we are talking of antenatal coverage, we need to understand which tests should be offered to the women, when should we offer them, how frequently, and which patient should be offered which other investigations apart from the routine ones. This will vary depending on whether this woman is from a developed country, developing or an underdeveloped country, what is her socioeconomic condition, what is the level of care to which she has come, whether she is in a primary care or a tertiary or a secondary care, and whether she belongs to a high risk or a low risk population. So all her investigations will vary and management will vary depending on that. The things which are important in assessment and management of the women are again a detailed history, meticulous examination, certain screening tests, preventive measures that should be given during antenatal care, and the treatment. And the thing that we'll be discussing today are the screening tests. So the aim of the screening test is to detect a disease or a condition in early stages. It is for any screening test. The disease that should be screened for should only be the one where treatment can be offered, and the potential benefit of detecting that particular disease should outweigh any particular risk. So the investigations that we do during pregnancy fulfill all these criteria. In pregnancy, there are certain tests that are mandatory or should be done in all women, and there are certain optional tests But we would advise that amongst the optional tests, at least blood sugar and thyroid function tests should be done for all. Hemoglobinopathies should be done for high-risk population. Clinically indicated torch test or toxo-CMV rubella screening should be done. It is not at all a routine test for all, otherwise it becomes a torture test. It is very difficult to interpret, and then it usually leads to mismanagement than correct management. And of late, the new test that is coming because of evolution of fetal medicine is biochemical screening for aneuploidy. And I'll take you through them one by one. So the basic test that we do for all women is estimation of hemoglobin to see if she is anemic or not. Because anemia still is the most important cause of maternal mortality in our country. It is because most of the women are either not diagnosed or not adequately treated. And this is very easy to prevent. At the first antenatal visit, a hemoglobin estimation should be done in all women. This should be repeated as the pregnancy goes at 24 to 28 weeks, and one last at or near term. If the woman is anemic, she is undergoing treatment, then it may be done more frequently. Diagnosing anemia is not enough. We also need to ascertain what is the type of anemia after looking at a hematocrit and red cell indices. And it is a good practice to do a complete blood count if feasible and possible, because that will also help us to diagnose any infection or thrombocytopenia in the mother. The normal hemoglobin in first and third trimester is 11 gram%. And in the second trimester, because of the physiological hemodilution, it is 10.5 gram. So if we diagnose a patient to be anemic, the next step is do her red cell indices and look at the MCV or mean corpuscular volume. If the MCV is decreased or what is called as microcytic, then we go ahead and do her serum iron studies and ferritin. If the ferritin is low, then it is suggestive of iron deficiency anemia. And if the ferritin is normal, then this woman should be advised HPLC to look for thalassemia. If it is normocytic, then it can, thalassemia is important not only because we need to treat the mother, but also because if her husband is also a thalassemia minor, then there is a 25% chance, because it is an autosomal recessive condition, there is a 25% chance that their baby can be thalassemia major. And if the baby turns out to be so, then for the entire life, the baby will depend on blood transfusion for its survival. And these children usually do not survive beyond third or fourth decade of life. So it is a very, very easily diagnosable condition in the mother and preventable condition in the baby. For the whole life, as blood group remains same, similarly the thalassemia condition of the mother will remain the same. So if we can diagnose all the antenatal mothers during pregnancy, whether they are thalassemia minor or not, and treat them, probably one day we will be able to eradicate thalassemia from our country or all over the world. The next is, if it is a normocytic anemia, then we need to look at the reticulocyte count. If it is increased, then we can think of hemolysis or ongoing blood loss. And if it is not increased, then we need to think in terms of bone marrow diseases or leukemia. If it is macrocytic, that is commonly seen in B12 and folic acid deficiency, then we should try to diagnose the same and treat them. Nowadays, B12 is also available in the form of nasal spray. So, and it is claimed that the efficacy of nasal vitamin B12 spray is as good as injection. So this can be very routinely offered to the patients. The irony is that we tend to overlook polycythemia, and this is associated with preeclampsia and renal abnormalities and can lead to preterm labor and IUGR, and hence should be looked for. A word about hemoglobinopathies. They are the most common single gene disorder, and the carrier frequency is high in certain ethnic groups like in Punjabis, Marwadis, Sindhis, and in Maharashtra, Madhya Pradesh, Orissa, and some part of southern India. So the diseases vary depending, and like thalassemia is more common in northwestern part of our country, sickle cell is more common in Orissa, Madhya Pradesh, and hemoglobin E is more common in the eastern part, so E and eastern. So we need to diagnose these conditions because they can be diagnosed by a very simple test, that is HPLC, and if it is possible, to diagnose in the couple also, then we can predict the risk of affection in the baby. And if it is MCV is low, as we have discussed, and MCH is also low, and our HbA2 comes out to be more than 3.5%, then the patient can be diagnosed to be thalassemia carrier. The next test that is routinely done is blood group, and to look for whether she is RHD negative or positive. That is whether she is AB negative or positive. Why we need to know this is because there is a huge increase in over-the-counter abortions nowadays, and college-going girls and women who are living in the remote areas where they are not able to go and meet the doctor and they don't want the child. They just go to the counter and take an abortifacient and abort. But it is very important to see that if she is Rh negative and her partner is Rh positive, then she does not take, and if she does not take a anti-D immunoglobulin, then she is likely to become isoimmunized. And this leads to a worsening in whole of her obstetric history. We are a center where we do lot of intrauterine transfusion for Rh isoimmunized children, and we see that the most common reason in them is they did not take anti-D when they took an over-the-counter abortifacient. So this is an important and a preventable cause. Because if once she is isoimmunized, her pregnancy outcome is going to worsen after each pregnancy. If she loses one baby at term, next pregnancy she will lose at 30 weeks, next she will lose at around 20 to 25 weeks, and next she will lose at 20 weeks. So it is going to be worse in every pregnancy. So the best pregnancy is the pregnancy which she is carrying. And we also need to know that there are certain minor blood group antibodies that can lead to isoimmunization. And the test to diagnose if she is isoimmunized or not is indirect Coombs test. So what you as medical student, MBBS student need to remember is that if any pregnant woman is Rh negative, please advise her an indirect Coombs test. If she is negative, she should be given anti-D. If she is positive, that means the baby might have fetal anemia, and please refer her to a center like ours where we can take care of them. The third is glucose tolerance test. We all know that India is going to become the diabetes capital of the world. It is increasing, the incidence is increasing very rapidly. Not only it affects the mother, but also the fetus. The most detrimental outcome in the fetus can be stillbirth. So the patient is carrying her pregnancy and suddenly we find that this baby is no more. If these tests are not done, then the doctor can be sued for this, because this is a very important part of antenatal care. It is also important to remember that these patients are likely to develop diabetes in later life. So maybe if we can diagnose diabetes in pregnancy, then later on we can tell them to have a lifestyle modification and take care of her diet and her blood sugars. There are many tests by which we can do. So these are the various tests and these are their sensitivities. The test that is followed in India is DIPSI. That is, since the patients goes very less likely to the doctor. The number of patients that go for antenatal coverage maybe only once or twice they go. So we can do at least DIPSI test by which we give a patient 75 gram glucose and do the test after 2 hours. But ideally, if we want to pick up more number of cases, then it is good to follow IAD PSG guideline. The timing of the test, initially it was thought that it should be done only at 28 to 24 weeks. But if we follow this, then we'll be missing a lot of patients who are already type 2 diabetic who never went to a doctor. So it is a good practice to do a blood sugar test in the first trimester or in the first visit. Now the question is, you may ask that, doctor, when she comes in the first trimester, she has a lot of nausea and vomiting, and how will she tolerate this much blood glucose? So what we would advise is just get her plain fasting and PP done. And after 16 to 18 weeks, you can get a GTT done. But if you're working in a remote setting, at least get it done by 24 weeks. If it is normal, 28 weeks. If it is normal, 32 weeks. This is the new guideline. The next is hypothyroidism. Whether to check for hypothyroidism in pregnancy or not is a matter of debate, and it is still going on. ACOG, Cochrane and American Thyroid Association says we should not screen. But Indian Thyroid Society says we should screen because there is a large belt in India who are hypothyroid because of iodine deficiency. Why do we need to diagnose thyroid disorders in pregnancy? Because if the woman is hypothyroid and we have not treated her adequately, her child can be mentally retarded. It can be as sick, it can be as serious as cretinism to as mild as an IQ of 1 or 2. What is important to remember is that TSH is the first line screening test to assess thyroid status in pregnancy. If the TSH is less or more, repeat a free T4 to see what is the type, whether it is a hyperthyroidism, hypothyroidism and clinical or subclinical. If it is hypothyroidism and clinical, we must treat her throughout the pregnancy. And if it is hyperthyroidism, that she should be treated with thioamides. In a patient who is hypothyroid, monitor with TSH. In a patient who is hyperthyroid, monitor with free T4. This is very important to remember. Next is VDRL. The incidence of syphilis in India has gone down drastically, and rather incidence of other sexually transmitted infections have increased. And what we need to remember one line about syphilis is that if somebody is VDRL positive, go and do a TPHA and treat and screen the partner. If she is TPHA negative, forget it. If she is TPHA positive, treat her with penicillin and don't repeat VDRL because it will continue to remain positive. It will not go ever in her life. Next, HIV. We know that the incidence of HIV is falling and still we have 2.3 million people living with HIV. Why is it important to screen these women? First, probably they will never come back to us for her treatment in her life. Second, we need to protect ourselves from the infection. Most important cause is that if we diagnose and we treat them, we can reduce the incidence of HIV infections in children by 90%. It is seen that PPTCT reduces the incidence from 15 to 45% if untreated to 5% if they are treated, and hence universal screening is advised. Regarding hepatitis B, Uttar Pradesh and in and around Lucknow there is endemicity of hepatitis B, and it is very important to screen for the same in pregnancy. Without post-exposure prophylaxis, if these children are born to these mothers, 40% of them will develop chronic hepatitis B, of which 1/4 will eventually die of liver diseases. So what can we do about it? During delivery, we should take universal precaution, and if the patient is found to be HBsAg positive, do her hepatitis B E antigen, which shows infectivity. If it is positive, do her DNA load, refer them to our center. We do her DNA load. If the DNA is very high, then we treat her with an antiviral treatment, which reduces the viral load and reduces the risk of transmission to the baby. After the baby is born, there should be passive and active immunization of the newborn within 12 hours of birth. So we need to be prepared for these once the baby is born. Hepatitis C, again, it's a matter of controversy whether we should do or we should not do. But the people who should be screened definitely are who have received blood transfusion before 1992. Sure, the number must be less. IV drug abusers and those who have undergone body tattooing, HIV and HBsAg positive because they are known to occur simultaneously, the partners who are having these viral infections, any healthcare professional who is working in a dialysis unit or in an embryo transfer unit from an anonymous donor, and unexplained raised liver transaminases in pregnancy. Another set of viral infection, as I said, was TORCH. TORCH stands for Toxoplasma, Rubella, CMV and herpes. This is a whole topic in itself and I will not go in the details. The question here is, who should be screened for TORCH infections? Any pregnant patient who gives history of fever with rash, any patient who has lymphadenopathy, exposure to a serologically proven cases like somebody who had rubella in the family and because it is a droplet infection, she got exposed to it, or if ultrasound is having features of IUGR, high drops, any calcifications in the brain or heart, whether there is increased or decreased LICA, and if the child is showing cataract on ultrasound examination. Why we should screen? Because they account for 2 to 3% of birth defects. The affection is maximum in the first trimester because placenta is very, very permeable. So we need to take a good history when they come to us in first trimester. And some of the patients, some of the babies who have been affected with CMV in utero can have a long-term sequelae. It is possible to diagnose these conditions prenatally by doing an amniocentesis and doing a PCR for Toxoplasma, CMV and rubella. How should we interpret? Well, Toxoplasma, rubella, CMV and herpes, they behave differently. But the thumb rule is IgM shows recent infection, IgG shows a past infection. That is, she has already got infected to the disease and she has antibodies in it. So if a patient is IgM negative and IgG positive, there is no need to panic. If she is IgM positive and IgG also positive, then she most likely has suffered an acute infection, and we need to do an avidity of the same virus to see whether she had a recent infection or a past. If avidity is low, we can say for certain that her infection was within last 12 to 16 weeks. But if avidity is high, then we can rest assured that if she has come to us in first trimester, probably she got an infection before 16 weeks and there's nothing to worry. If only her IgG is very high and IgM is negative, then next test that we advise is doing it after 2 to 3 weeks from the same lab. That is what is called as in a paired sera. The next test, so apart from these blood tests, what is advised is a urine test. In the urine, we look for albumin to rule out any infection or preeclampsia or renal disease, and we quantify them by a spot protein creatinine ratio and a 24 hours urine protein. If it is more than 0.3 in spot PC ratio, then we can say that probably this is definitely more than normal and we need to evaluate the patient. And there are strips that are available, so we can check for urine protein in an OPD visit only. We don't need to send her to a lab if it is not possible. And we need to look for the sugar to see if probably the patient is an overt diabetic. Now, Foxy also recommends that any woman who comes to us, we should advise urine culture in her first visit to rule out asymptomatic bacteriuria. Out of pregnancy, any woman will complain of dysuria, increased frequency. But in pregnancy, it is seen that because of the progesterone, the ureters are less motile, the chances of stasis of urine in the bladder and the kidney is more, which increases these women or predisposes them to urinary tract infection. If untreated, it can lead to pyelonephritis and preterm labor, and hence advising a simple test is very effective. What we need to remember is that it has to be the first morning urine. That is, the urine should have stayed in the bladder for at least 4 to 6 hours. We need to tell her how to collect a clean catch midstream urine. Otherwise, the report can falsely come to be normal and we will miss this infection. Ultrasound is now a new machine that has come, and that is how the digital India is improving. Almost all the places in PHCs and district hospitals, we have ultrasound facilities with us. So it is very important that every woman should have at least one ultrasound examination before 24 weeks of gestation. This will confirm her pregnancy. So the important thing is that first it tells us that yes, the pregnancy is intrauterine and it is viable. Next, whether she is having a twin, because if she is having a twin, and more so if she is having a monochorionic twin, she is at a very, very high risk of complications later on, and she should be referred to a tertiary care center. In the initial stage, not when the complication comes. Next, what is the gestational age? So we can measure the crown rump length in the fetus and measure the gestational age, which is the best parameter. Once the measurement of gestational sac is not very accurate, and once the baby grows beyond 16 weeks, the accuracy falls down. whether the baby is having any malformation, like we can see that the baby is having a cleft lip and a palate here on 2D and 3D ultrasound. We can assess the growth curve of the baby. Suppose the baby was normal to grow with, if it is IUGR, it will fall in this area, or if she is a diabetic, it will fall in large for gestational age. So we need to look at the growth of the baby. And if it is IUGR, then we need to look at the Doppler of the baby, whether there is uteroplacental insufficiency. This is one condition which, if not picked, is very, very likely to lead to stillbirth. So in these babies, we need to sometimes do a Doppler weekly or twice weekly to decide when should we take this baby out. Otherwise, the baby may die in utero. So to prevent stillbirth, it is very important to look at the growth of it, not a single ultrasound, but to look for the growth of the baby. And if there is IUGR, look at the Leica and look at the umbilical Doppler. And if the Doppler is abnormal, then we need to again refer this patient at a tertiary care center where there is facility for neonatology so that these patients can be timed for their delivery. And last, with advancement in fetal medicine, screening for fetal chromosomal abnormalities has also evolved since 2005. And it has taken a lot of improvement now. It is advisable that it is not that just it is for a high class or a woman who is very old, because it is seen that most of the babies of Down syndrome are born to women who are less than 25 years of age. And hence, all women should be offered, it is not that it should be done, but at least they should be offered a screening test for fetal Down syndrome, which is called as a double marker or a quadruple marker. Triple marker is obsolete and it is better not to be advised, because biochemical screening are a major cause of fetal loss and handicap. They are untreatable conditions. So if they are diagnosed well in advance, these babies can be aborted. Some conditions are likely to recur in subsequent pregnancies, and hence it is important to pick them up. One is to prevent the birth of babies who are mentally challenged or physically challenged. And there are effective screening technologies for the same, and diagnosis can be done by doing a CVS or amniocentesis. So if they cannot, because they cannot be treated, it is best to prevent the birth of these babies. And the most common aneuploidies that we have is Down syndrome, as we can see in this baby who has the eyes far apart, which is hypertelorism, depressed nasal bridge, short stubby fingers. And this test is done. So this is a image of, test is done from maternal blood, and this is somehow how the report comes. So if it says that it is below the cutoff in the green zone, patient is low risk. If it is in the yellow zone, she needs some more tests. But if it is in a high risk, then she needs an invasive testing or a definitive test. When we are ordering for these tests, we need to give this information very carefully, because the machine calculates the final risk based on these parameters. And the latest test that has come is NIPT or NIPS, or non-invasive prenatal testing, or cell-free fetal DNA. So this is a test in which has got a very, very high sensitivity of 99.3% for Down syndrome. It can look for other chromosomal abnormalities also, but it is less sensitive than that. So it is most commonly used for Down syndrome. So if a mother is at a high risk in her double marker or quadruple marker and doesn't want to go for an invasive testing, this can be offered. This can also be offered in patients who have a previous child with Down syndrome, or in the mothers who are more than 35 years of age. So this test, what it does is, from the maternal, the principle is that the fetal DNA goes in the maternal circulation after 9 to 10 weeks of gestation. So when the mother's blood is taken and the mother's blood is separated from the fetal blood, or I can say that fetal blood, which is green, is separated from the mother's blood, and it is counted. And this tells us whether, if there is more than 50% increase in the fetal derived chromosomal DNA, then we can say that this fetus is at very high risk of having Down syndrome. And preeclampsia is another maternal disease which can be screened for with a very high sensitivity, and there is an effective treatment of the same if it is started before 16 weeks. So the screening for preeclampsia is done by maternal history, mother's mean arterial pressure, her sample for PAPE and PLGF, which is done in double marker, and to look for uterine artery. And if she is at high risk, giving her just a low dose aspirin, that is 75 to 150 milligram of aspirin. This is a controversial issue. What dose is correct? We advise 150 milligram as per the aspirate trial. So if the woman is started on 150 milligram of aspirin at bedtime before 16 weeks of gestation, that is before the first wave of placental invasion occurs, we can prevent the incidence of preeclampsia and eclampsia by 94%. So this is something which we need to remember and start in our practice. So the take-home message is take a look at the hemoglobin. It will prevent maternal mortality and help us in eradicating thalassemia. When you do a blood group, look at if she is Rh negative or positive, and if she is negative, screen the partner, do an ICT, and prevent a worsening of her obstetric history. Look at the blood sugar, because you're not only protecting the mother and the baby now, you are also decreasing the incidence of type 2 diabetes in women in her later life. If the woman is at high risk, viral infections like HIV, HBsAg and VDRL should be screened for in first visit, and in high risk patient we can repeat them in the third trimester to prevent mother to child transmission. Urine test is very simple but very effective, and it will go a long way not only in protecting the mother's health but also in preventing prematurity. 3 days back, we've a patient who is wife of a staff nurse in a nearby district hospital was referred for preeclampsia. When we worked her up, we found that she was a case of severe renal failure with a creatinine of 3. If this woman wouldn't have been picked up, she would have definitely landed up in acute kidney injury at the time of her delivery, and probably she would have lost her life if not treated. So by doing a simple, and her urine protein was 3+. So this was the first thing that we did. We went back and looked at her creatinine, which was 3. So urine test can be as helpful as this in saving a woman's life. Ultrasound is now available everywhere. We should try to not only pick up the congenital malformation, we can also look for the placental abnormalities, look for placenta previa, any bleeding, and manage them appropriately. And biochemical screening, if done properly, and aneuploid babies, if detected timely, can save not only the family but also the entire society from a social and a financial burden. Thank you so much.